morning and good afternoon to those on the East Coast, and thank you for participating in today's webinar. And what we're going to be discussing today is ISMP's new self-assessment on high alert medications, and we're going to talk about how to conduct it and how to obtain the most accurate and useful results. My name is Alan Beta. I'm Executive Vice President here at ISMP, and I'm co-presenting today with Rebecca Lamis, who's also a pharmacist here at ISMP and also a former fellow. Becky has been intimately involved in all our self-assessments going back to 2010 when she did our fellowship here with us. Please note that your phone lines are muted, and if you're logged into your computer, you could submit your questions on the portal under the questions pod. If you're logged in using a mobile app, you can ask a question by clicking the question mark located at the top of your screen. Feel free to submit questions throughout the presentation, and we won't be taking any questions over the phone. If you'd like a copy of the speaker's presentation, you can access it under the Handout tab on the GoToWebinar portal. And with that, I'm going to begin our presentation. So our learning objectives are basically to go over the self-assessment and how it will benefit you and others, how to complete the self-assessment and send your results to ISMP, and then we're going to outline the steps recommended for full engagement in the process. And a lot of that material will be done by Becky. So to begin, this is a front cover of the self-assessment, which is available on our website. And the self-assessment, those of you that are familiar with ISMP know that we've been doing self-assessment since back in 2000. We've done 3 editions of a hospital self-assessment, 2 editions of a community pharmacy self-assessment. We've had 2 editions of an antithrombotic self-assessment, and we've had oncology self-assessment, automated dispensing cabinets, and several others. So this is our latest and newest, and we want to also up front thank the FDA, which provided the grant funding to do this self-assessment. And there's 11 categories, which I'm going to go over, and of course it's focused on high alert medications. And as we know, these are the medications that have a higher risk of causing significant harm when they're used in error. So why did we choose those? For that very reason that I just said. And if we go back to 2013 on some studies that were published in the Pennsylvania Patient Safety Authority reporting system, we could see that the high alert medications have been involved in many of the harmful errors. And they've usually come to the top with the top medications that are involved in serious harm or adverse events that actually lead to patients being admitted to the hospital. And from this list, you could see that those medications that actually rise to the top, we're seeing the insulin, heparin, warfarin, opioids, and several others, but we're actually going to talk about even more than these in this self-assessment. So here are the 12 categories. Well, there's really 11 categories, but there's a general high alert medication section I'll talk about in a few minutes. But we go from neuromuscular blockers down to opioids, and each of these are categorized in the high alert assessment. And this is a little bit different from those of you that have done our previous self-assessments in that each of these are basically a standalone, so that you could, if you do not use some of these high alert medications in your institution or your ambulatory site, you could basically just pick and choose which ones you do want to use. But first you have to finish the general high alert medication section. We also have several endorsing organizations. So you can see from here, from the American Association of Colleges of Nurses, the ASPN, American Society of Health System Pharmacists, ECRI Institute, the Joint Commission has also endorsed this self-assessment, and many of these organizations are also helping to promote the self-assessment for us. The assessment includes, I'm going to talk just a little bit before I hand it over to Becky. The assessment includes frequently asked questions section, and this is a section that we would recommend that you take a look at before you start the assessment. And actually, we've had these in our other assessments, but these are just those items that we know beforehand that we may get questions on, or when we did our testing of the assessment, questions may have come up, and then we added them before we actually launched the assessment. The assessment also contains key definitions, and these key definitions, there are about a dozen or so of them. These are definitions that we came up with the help of our advisory committee, so they may be a little bit different than definitions of terms that you may be familiar with, but when doing this assessment, it's good to take a look at these so that you're prepared on what we mean by some of these key definitions and terms. There's also additional defined terms that are found in a glossary on page 89 of the assessment. And within the assessment, the online assessment, these terms are designated in bold, small cap letters. And if you're doing the online version, if you just home over these, they actually go back to actually show you what the definition of that term is. So even if you print the copy, you'll see that these are bolded, and you could look in the definition glossary for what we mean by these terms throughout the assessment. The assessment items are critical safe medication systems and practices, expert opinion or evidence-based, and we did have a national advisory group, as we do with our other assessments, and this group was very active, and we had many phone calls going over these items, and the group consisted of pharmacists, nurses, specialized pharmacists in pediatrics and women's health. We also had anesthesiologists, because of many of the sections in this, also had hospitalists. So we had a wide variety of practitioners participating in this, along with our entire staff here at ISMP. And actually, that's why we were a little late coming out with the assessment, because we did spend a lot of time, and we'll go through a few of these items too on today's webinar, on what exactly tweaking some of these items so that we could actually get out some of the best practices out there. I do want to remind you, these aren't minimum standards of practice. Some of these are stretch goals, and that is how we have actually set up our other assessments too, for people to go through this, see where they stand now, and then actually try to use some of these for some goals that they want to set for the future. The scoring guidelines, once again, are a Likert scale from A, there has been no activity, up to E, that this item is fully implemented for all patients, orders, drugs, or staff throughout the institution, clinic, ambulatory center, who's ever doing this assessment. And then there's also some items that are marked not applicable, and those are items that, such as you may not treat pediatric patients at all in your institution. You may not do oncology at all in your institution. So even with some of the general items that we may be asking, there are some NAs in there that you would actually click that box. And there's also explanations of exactly what we mean by those not applicable. The scores are weighted, and those weights are based on the impact of safety, ability to sustain improvement, and they go from a low of a 0 up to a high of 16. And those were weighted here internally by ISMP. Once again, if you're familiar with our assessments, many of our other assessments also had weighted scores. And what these weighted scores help to do is actually have some comparisons. So it's easier with the comparisons. These weights are then put into percentages, and that's a way that when the assessment is over, those that have submitted results, we will have a workbook available for them, and then they could actually do some comparisons how they looked to the national aggregate scores. And now I'm going to turn it over to Rebecca to actually go through the online form and the web page.
Thank you, Alan. Good morning or good afternoon, everyone. Thank you for joining us today. All of the components of the assessment can be accessed from our website by going to our self-assessment webpage and then by clicking on the link for the high alert assessment. On the webpage for the high alert assessment, which is what is shown on the left, you can view, download, or print a copy of the workbook, which is the PDF version of the assessment, either in its entirety or just the sections of the assessment that you need. We have had a few requests to provide the assessment in a different format other than the PDF, so we will also be providing an Excel spreadsheet of the assessment items by the end of this week. This webpage also includes a link to the frequently asked questions that Alan mentioned, which contains general questions and answers as well as questions and answers for specific self-assessment items. There is then also a link to the online self-assessment form, which is what appears on the right. The online form can be used by facilities to complete the assessment, but it is where all facilities, no matter how they choose to initially answer the demographic questions and assessment items, will need to enter their information in order to submit to ISMP. Each participating facility will need to create a user account in order to utilize the online form. And through the online form, facilities can also reset their password to their account if they provide an email address. And then, as I mentioned, it's where all of the information is submitted to ISMP anonymously. Facilities can also access their results through the online assessment form. And I'll be going through the submission process and how to review your results more a little later in the presentation. Once we have aggregated the assessment results after the submission deadline, facilities will also use their created accounts to access the aggregate comparative reports that we have prepared based on the collected data. The assessment was developed for various healthcare facilities, including hospitals and long-term care facilities, as well as certain outpatient facilities, such as surgery and endoscopy centers and oncology clinics. The assessment is separated into sections by the 11 targeted high alert medications that Alan named earlier, as well as the general section that applies to most or all high alert medications. So again, as Alan mentioned, facilities really can choose which sections are applicable to them and those that they would like to complete. Again, as Alan mentioned, all facilities will need to complete the general section, but then facilities can choose one or up to all 11 of the high alert medication categories. We do encourage facilities, though, to complete as many of the categories that are applicable to their location site as they can. The first section of the assessment is the section that contains the general demographic questions. There are two sets. One is for hospitals, and long-term care facilities, and the other is for the outpatient facilities. There are 19 or 13 questions, depending on your facility type. And these questions cover various topics, including bed size or number of patient visits for the outpatient facilities, location of your facility, as well as the services that are offered, if there are resident or student training programs, how pharmacy services are provided, the presence of certain specialty staff members, and the implementation of various technology. And with that, I will pass it back over to Alan, who will continue discussing the rest of the sections that are contained within the assessment.
Alan, I believe you're muted.
Yes, you're right. Sorry about that, I was muted. We already got one question on the Excel version of the assessment that will be available at the beginning of next week, and it may be available at the end of this week, but Becky could talk about that again to make sure with the exact dates when that will be. The general high alert medication section is that's a section that everybody has to fill out before they can move on to the categories. And there's 33 items in there, and it includes technology, dispensing, and basically they're questions. Many of these items are items that we didn't want to repeat in each of the categories, but they're actually items and best practices that would go along with all the high alert medications. So that's why we tried to group them here, and they're also a way for us when we do the final results and actually do an article on this, or actually put some more publications out in our newsletters on this, a way for us to maybe sort some of this data. So there's about independent double checks, patient education, the learning culture. Again, these are items that go along with all the self-assessment categories and items. And you can see here on the screen too that, as I had mentioned, there's a few not applicable, and those do come into play if you don't use some of the medications that we may refer to in here in the general section. The next section on the assessment, as I just mentioned, once again with the general medications, some of the questions in here are pharmacists work on site in patient care areas at least 8 hours each day, performing clinical activities, standard protocols, order sets, express IV and neuroaxial high alert medication infusions in a manner and sequence that matches the entries on the medication administration records. And many of these items too, that if you're familiar with our publications, you've probably heard this information from us before, and is available also in a lot of our newsletters when we give recommendations, especially on some of the errors that we get in with high alert medications. The first section is the neuromuscular blocking agents, and there's one demographic question. So there are some demographic questions within each of these categories, and I'll talk about those, that basically may be something specific for that category of medications that, again, we may use to try to aggregate some of this data and differentiate some of the aggregate information that we do get in. There are 15 items, many of them on the common errors that we've received in through our reporting program, administration to unventilated patient, lookalike names, storage. And some of these items are refrigerated, non-refrigerated neuromuscular blocking agents are segregated. This is something that ISMP always promotes. If a neuromuscular blocking agent is ordered for a patient, it's not that in an environment that does not typically support mechanical ventilation, there is some verification by pharmacy before that agent is dispensed. And this is something, too, that we do receive errors in on this. So this is something that, once again, even with our anesthesiologist in this section, too, totally agreed and actually helped us refine some of these items. Anesthesia staff are provided with and use labeled pre-filled syringes. Something else that we always try to promote, that either from an outsourcer or from pharmacy, rather than using self-prepared syringes. And again, as you go through the assessment, this is something that, why it's on that Likert scale too for yourself, to see where you may fall into this. Is this throughout your institution, or is this just for some items? Next is on concentrated electrolytes. There's 26 items in this section, and they talk about electrolyte replacement therapy, parenteral nutrition, potassium chloride concentrate, and again, some of those common errors that we get in, the dosing errors, calculation errors, the product mix-ups. So we try to cover some of these categories for those common errors that we get in on concentrated electrolytes. And some of those may include that you do have standard order sets for parenteral nutrition, and that they list those additives in the same sequence, once again, as is the pharmacy computer order entry system and the automated compounder. Just like with the last section when we talk about that there's matching with that MAR, the medication administration record, this again is very important, and we may get errors when there's different sequencing or different matching of how terms or how the actual label may look compared to the order. Practitioners use a standardized facility-driven defined dosing unit of measure, millimoles versus milliequivalents to prescribe, label, and dispense. Once again, this is something, and this is something too that many of you may know with the American Society of Health System Pharmacists, through a grant they received from the FDA, actually has some standardized terminology and actually concentrations to use for IV medications that then would be carried on also what you would use in infusion devices. In vials containing concentrated sodium chloride are not stocked outside the pharmacy or dispensed to patient care units. So these are some items too that are included in this section. The next section, magnesium sulfate injection, we felt this, once again, it's on our high alert list, but we felt it also needed a separate category in here because there's a lot of mix-ups that we get in, especially with between oxytocin and magnesium, calculation errors, miscommunication. So here we have 2 demographic questions and 22 items. And these items, once again, may be addressing specific things such as preeclampsia and eclampsia, but also some general sections too on errors that we may get in from the in our error reporting program dealing with magnesium sulfate. Separate protocols and order sets have been established and are used for each indication for which parenteral magnesium sulfate is used. This is one of the items. Upon temporary stoppage of magnesium sulfate, the solution is immediately disconnected from the patient. And these are to address some of those errors that we get in, that it actually may be still connected to the patient and maybe restarted before it's supposed to, or if it's not supposed to be restarted. Practitioners use a standard facility-defined dosing unit of measure. It's again, just like with the concentrated electrolytes, and that it's documented for all adult patients and older pediatric patients above a specified weight. So again, these are items that are based on a lot of the errors that we may get in from magnesium sulfate injection errors. The next section is on moderate sedation in adults and children and minimal sedation in children. There are 40 items in this section. This is one of those sections, too, that took us quite a long time with our advisory group, and actually had several calls and also back and forth refining some of these items. But again, it's something that's very important. We receive a lot of errors in on confusion about onset of action, how you titrate some of these drugs, the failure to adequately assess and monitor patients, lack of preparation for some emergencies, and also with staff training. So again, that's why this section is quite lengthy. And some of the talk about reversal agents, if they're not administered electively, to solely decrease patient recovery time. So that we see this oftentimes, especially with naloxone or flumazenil, and that those agents aren't just used in that instance, that basically there's more thought put in on the actual dosing of these medications. Practitioners who titrate moderate sedation agents to effect have received training about each drug's onset, peak. Again, this is what I talked about with some of that staff training, and all practitioners, that's the physicians, nurses, any of those that may be administering some of these agents. Only trained healthcare workers administer oral sedatives to neonates and their pediatric patients in preparation for a procedure. And again, this isn't that something that's passed on to the parent or the caregiver. We do receive errors in on this. So that's something too that, again, these are just some of the items that are included in that section. Another category is on insulin, both subcutaneous and intravenous. Many of you may be aware that we just put out some insulin guidelines, and that those guidelines looked at the subcutaneous use of insulin. And in this category here, we actually look at both the subcutaneous and the intravenous. So there are 5 demographic questions in this section, and then there's 45 items. Again, this is another lengthy section, and we address pens, concentrated insulin, IV insulin infusions, and also insulin pumps. And based off a lot of those errors that we get in with the concentrated insulins, as you know, ISMP has published many errors on the concentrated U500 insulin. Now we have several other concentrated insulins out there, the U200, U300, insulin pens. Again, if they're used for more than one patient, we've published information on this. The CDC has published information on this. Many groups, and actually on an international scale, have had issues and errors with repeat use of some of these pen devices on more than one patient. And communication of patient monitoring results. Again, this is something else that we've received many errors in, where numbers may be jotted down on a piece of paper and they're confused with room numbers, or if they're the glucose numbers. And again, this is that communication of, especially with the many hospitals, they're using the glucose monitors on the patient care units, and how does that information get documented and communicated to the practitioner that's actually maybe dosing some of these insulins. So again, in this section, we have a barcode, bedside barcode scanning is utilized, and insulin vials are dispensed and stored in the patient care areas. There's a process that enables the application of patient-specific and drug-specific barcode labels on clinician-prepared syringes to facilitate the scanning process. For all patients on insulin, a risk assessment is conducted so that those patients can be identified and specifically targeted for prevention interventions. And again, this is another section that I have to say that the advisory group and our staff spent a lot of time on, with actually even tweaking some of the wording of a lot of these items in here. And then with the U500 insulin, that pharmacy dispenses either pens or prefilled syringes for individual patients, and the U500 insulin vials are not distributed to patient care areas or stored in patient-specific vents. So this is something that, once again, we've been talking about this for decades with the U500 insulin, and so there's items in there addressing the concentrated insulins. Another category, lipid-based medications and conventional counterparts. There's just 9 items in this section, but we felt it was important to include as a section in the high alert assessment, because we do get mix-ups with these formulations. And there's more lipid-containing products that are coming on the market. We have dosing errors, name similarity, and also by staff that may not be familiar with the items. So again, we felt this was important. Some of the items, whenever possible, only the lipid-based or conventional formulation of a drug, not both, is available on formulary. You may not always be able to do this. But again, this is something where we see errors, and if it's possible to just have one so that all staff are trained. The computer system is set up for that. The way it's dispensed is set up for that, so there isn't that possibility of making a mistake. Drugs available in both lipid-based and conventional are stocked only in the pharmacy and dispensed for specific patients as prescribed. And then there are a few items like this one where we may have an exception. And here, with this exception, is the bupivacaine may be part of anesthesia stock outside of the pharmacy. And the computer order entry system performs dose range checks when entering all lipid-based drugs or their conventional counterparts. The next section is on methotrexate for non-oncologic use. This is another small section, 7 items, but we felt it was important enough to have a category on its own. As you know, the ISMP for the last 4 years has been putting out its targeted best medication safety practices, and methotrexate for non-oncologic use has basically been on that through the first 2 revisions of those targeted best practices. And this is something that we've been harping on also on an international scale with the accidental daily dosing versus weekly dosing for those patients that are receiving the methotrexate for a non-oncologic use. So again, it's based on our errors and also based on, with our advisory group too, feeling that this was an important category that stand on its own. So we talk about some of the items, some of the same type principles that we do in our best practice recommendations, such as computer order entry systems default to a weekly rather than daily dosage regimen, prescriptions for use of non-oncologic upon discharge only include the number of tablets or dosage forms needed for the weekly dosing, not to exceed a month's supply. And patients who were discharged on methotrexate receive clear verbal and up-to-date written instructions. Again, as I mentioned, if you're familiar with our best practices, many of these recommendations are the same. The next is on chemotherapy oral and parenteral. There are 5 demographic questions in this section, and again, it's a lengthy section with 48 items. There are some items that you may have seen if you've done our oncology self-assessment. That was the international self-assessment we did with ISMP Canada and ISHOP. But again, these are from errors that we have received in, and actually from many of the recommendations from those of our advisory board also. And again, they cover the miscommunication of orders, compounding errors, labeling confusion, the accidental intrathecal administration of alkaloids, as we know with the vincristine, lookalike names, and again, staff training. So some of the items in this section, we recommend gravimetrics is used to confirm unexpected weight and volume of a compounded sterile preparation containing chemotherapy. That vincristine is dispensed in a mini bag. There are many organizations now, and again, even WHO, the World Health Organization, that recommends this, and we've been recommending this now for well over a decade. In compounded sterile preparations of chemotherapy solutions, the total volume to be infused is expressed on the pharmacy label, which includes the volume of all additives. This is something else that we've had errors in, and also we've reported from errors from ISMP Canada that occurred when the total volume of the infusion actually wasn't included on the label. Next section is anticoagulants. There's only one demographic question in here, but there are 43 items. There are some general items, and then there's some items that are for the specific anticoagulant items. And again, these are, as the others, based on many of the errors that we receive in, that on duplicate therapy, accidental stoppage, dosing errors with the infusion rates, lookalike names and packaging, food and drug interactions. So again, this is something that even in the beginning, when I talked about throughout the years with the studies, that anticoagulants always is in usually the top 5 of those harmful errors that usually get reported or that we see in the literature. So with the anticoagulants, we have some items with when orders for antithrombotics are entered, the computer order entry system alerts practitioners if the patient has received the patient has received an antithrombotic, including anticoagulants, even a one-time dose within the prior 24 hours. Prior to ordering unfractionated heparin or low molecular weight heparin, initiating the use of heparin catheter or flushes or using heparin-coated catheters, a history of HIT and or allergy to heparin is determined, and the abbreviations, no AC, that this is from errors that we have received in that basically they were taken as no anticoagulant. So that we look, and again, you know how ISMP, we have our dangerous abbreviations list, and these are things that will always will crop up, especially with some new agents or in agents with new mechanisms, and there'll be acronyms or abbreviations that actually are not widely understood by everyone. Next section is on neuromuscular opioids and our local anesthetics. 32 items in this section, and again, based on accidental IV administration, respiratory depression, lookalike names and packaging again, which is a familiar theme in many of these categories of medications. Staff training, once again, as we've seen, that is included in a lot of these categories. and the injection of medications, the drugs that may contain preservatives when they're supposed to be preservative-free. So some of the items in here are neuromuscular opioids with or without local anesthetics are not dispensed to clinical areas, in batches that also contain medications for other routes of administration. And again, we've had some fatal errors when some of these agents have been administered IV or have been administered in place of another medication. Neuromuscular opioids or local anesthetics are obtained by the person who will be administering the drug and only brought to the patient bedside immediately before they are needed. And infusion pumps used to administer medications and solutions via different routes are not stacked in the same pool, the IV pools. Again, these are based on errors that we've received in, and many of those serious or fatal errors. And then the last section is on opioids that I'm going to go over. And again, this is another lengthy section. It actually has 60 items, and we know that, again, opioids are usually at the top of the list when we see with adverse drug effects, adverse reactions even with medications. And again, some of the errors that we get in with wrong drug selections, dosing errors, oftentimes it's differentiating between opioid naive or opioid tolerant patients, monitoring of the patients, patient-controlled analgesia by proxy, and once again, the look-alike packaging, and also there's some staff training in this section. In some of the items in this section is the processes in place to verify that the patient is opioid tolerant with chronic pain before dispensing extended release or long-acting opioids that are indicated only for these patients. So once again, this is something that we spent time on with our advisory group, and we have received many errors in with opiate-naive patients receiving the long-acting opioids for extended periods of time. Patient-controlled anesthesia basal infusions are not used initially in opioid-naive patients. Reliable method of measuring the adequacy of ventilation and airflow. And one example would be capnography. Is used to monitor all patients receiving supplemental oxygen. And this is something that even the Anesthesia Patient Safety Foundation held a meeting, a conference several years ago addressing this issue. And again, there's a lot of fatal errors that have occurred because of just using something such as pulse oximetry on patients that also may be receiving supplemental oxygen. And that's not warning enough on how these patients may be handling the medication or going into respiratory depression. And outside the pharmacy, morphine and hydromorphone are stocked in different strengths. And again, this is something that we've come up with as a recommendation and also was supported by our advisory group, and we have reported on before. So with that, I'm going to turn it back to Becky, who will actually talk about completing the assessment and how you do that to get your codes and to get online. Becky?
Thank you, Alan. Regarding that question that was asked, you are correct. The Excel file will be available by early next week or hopefully at the end of this week. So to complete the assessment, we would recommend that you first review the assessment workbook, which includes all of the detailed instructions, all of the demographic questions and assessment items, and also review the document containing the associated frequently asked questions. Each facility should complete this assessment separately. So if you are part of the health system, each facility within that system should complete the assessment individually, even if some practices have been standardized across the system. Each facility should also establish an interdisciplinary team that will work as a group to complete the assessment. As medication use is a complex and interdisciplinary process, a self-assessment which encompasses the entire medication use process, not just the prescribing end or pharmacy practices or nurse administration. It shouldn't be completed by just one discipline. The value and accuracy of completing the assessment is greatly reduced if only one discipline completes it, as the items require input from multiple disciplines. Not only does completing the assessment as an interdisciplinary team provide your organization with a much more accurate picture of what actual practice is like, but we also think that completing the assessment together can lead to some insightful discussions around practices that certain team members may otherwise be unaware are occurring or not occurring. The instructions in the workbook or PDF list the team members who we think should at least be a part of your core team, and that includes a combination of senior leadership and frontline staff, again, from all disciplines that are applicable to your healthcare setting. So having a senior facility leader and medical nurse and pharmacy leadership, and then frontline nurses, pharmacists, and physicians, and any medication safety or risk management specialists. There needs to be a combination of both leadership and frontline staff, as there may be practices that are occurring that leadership may not be aware of, that only the frontline staff would be able to speak to. And having leadership involved also sends an important message about the facility's commitment to making medication safety improvements. It should be established up front with the group that during the assessment process, all individuals are to be as open and honest as possible, and that everyone should feel comfortable speaking up regarding the practices that are occurring. We also recommend that you choose a team leader or leaders from your core team that will be responsible for keeping the meetings on track and compiling and submitting your facility's responses. Your core team will also need to decide which of the 11 high alert medication categories you would like to complete. And based on that, you may need to add additional team members to evaluate high alert medication categories where they may have more expertise using those medications. Finally, your team will need to decide how you plan to complete the assessment. So for example, either by printing the PDF of the assessment and writing down your team's responses, entering your group's responses into the online form during your team meetings, and or utilizing the Excel file that we'll be providing. The team leader may want or need to verify some of the general demographic information with others outside of the first team meeting, but during your first team meeting, that's when you could need to complete the general demographics and general self-assessment items. Prior to and during all of your team meetings, we would suggest providing team members with a copy of the items that are being discussed. Your core team would then meet to complete each of the selected high alert medication categories, along with any additional team members who you have selected to also be on your team, whose expertise is in using those medications. We also suggest that you may want to record any discussion generated around each of the self-assessment items and the rationale behind that selected choice. And this can just provide some insight into why that choice was selected and may help you as a facility when you're moving forward with implementing some improvements. One important point that I wanted to mention is that when evaluating the assessment items, it should be based on what actually occurs, not what can be found in current policies or what ought to occur. Completing the assessment shouldn't be viewed as a test, but it's instead meant to assist facilities in uncovering opportunities for improvement. Although some self-assessment items do specifically ask about certain policies or procedures that are in place, the items usually also suggest evaluating whether these practices then are also followed. The most value from this assessment comes when teams consider what the actual practice is, not what a policy says that it should be. So that then system-based improvements can be implemented later to address the real vulnerabilities that exist within a facility. Finally, please submit your facility's assessment findings to ISMP by December 15th using the online form. As mentioned earlier, in order to submit your assessment to ISMP, one individual will need to create an account to access the online form. You can access the online form by going to the URL that's listed at the top of this slide, or again through the web page for the HiLERT assessment on our website. There again is that link to the online self-assessment form. Once you're on the online self-assessment form, you can click under the user login that says create new account. The individual creating the account for your facility will be required to create a username, a password, and then also select the category that best describes your facility type. So either hospital, surgery center, etc. There are two optional fields when creating an account. The first is an email address. So again, this is optional, but it allows you to reset your password through the online form, and it's like the only way we would be able to recover a username and your account if that username is lost or forgotten. The other optional field is if you're a part of a collaborative and have a collaborative code. This is where you would enter that code or codes if you're part of more than one collaborative. And Alan will be discussing more about this later in the webinar. Again, no matter how your facility decides to initially answer the assessment items, if you are submitting your information to ISMP, you will need to enter your responses into the online form. Based on the facility type that was selected when you create your account, you will first be directed to the general demographics that are applicable to your site. Once your facility has submitted those, then you'll be directed to the general HiLERT medication self-assessment items. And then once those have been submitted, that's when your facility will have access to all 11 of the HiLERT medication categories. And at that point, you can start, stop, submit those categories in any order that you would like. If there are demographic questions, though, associated with the HiLERT medication category, you will need to complete the demographic questions for it first before you can move on to the self-assessment items for that category. So again, the general demographics and general items both will need to be submitted before you're able to begin working on the 11 HiLERT categories. At any point while working on the assessment, you can log out and we'll be able to return to your assessment by logging back in. Again, but just please remember to hit the save button if you're working on the demographics, or the save and continue button if you're working on the self-assessment items. Also, please keep in mind that you won't be able to make any changes once you do hit submit. So just make sure that you are ready to submit at that point. After you have submitted a self-assessment section, so either the general assessment items or one of the 11 HiLERT medication categories, you will automatically be directed to a report of how you answered each item, your scores, and the maximum possible scores. So this is an example of the report that you would see after your facility has submitted a section, and this happens to be for the general HiLERT medications. You will see a green check mark next to the answer that your facility chose for each item, and the score that your facility received for that item, as well as the maximum number of points for that item. So in this case, this facility received 9 points out of 12 with their answer of D for item number 1. You will also receive your total score for that HiLERT medication category, the total maximum number of points possible, and then your score as a percent. So in this case, there were 446 possible points. This facility received 327 points, which resulted in a percent score of 73%. At any point after you have submitted the general self-assessment items, you can view and print your submitted information and results by going to My Account in the top right corner. You will be able to see the assessments that you have completed. In this case, only the general assessment items and the items for the lipid-based and conventional counterparts section have been submitted. You'll also see the date and time that those assessments were started and submitted, as well as your percent score, which you'll be able to use to compare your facility to the aggregate data of demographically similar facilities once those comparative reports become available. To view your full result, the full results for a assessment section, as was shown on the previous page or previous slide, you would just need to select View. You can also view and print how your facility answered the demographic questions by clicking on the corresponding links that are on the left side. Looks like we'll have time to answer questions if you have any at the end of this webinar, but at any time if you have any IT issues or questions about the assessment, please feel free to contact us either through email at selfassess@ismp.org. You can also go to the ISMP main website, go to the Contact Us link and select Self-Assessments from the drop-down menu, or through the online self-assessment form for this assessment, there's a Need Help link, as you can see here, where you can also contact us. With that, I'll turn it back over to Alan for the remainder of this webinar.
All right, thank you, Becky. It's an excellent presentation to go through, and hopefully those of you on the line that haven't begun the assessment yet, that you have a good feel for how it is set up and actually how to get your codes and actually how to submit the information. Just going to talk a couple minutes before we end here about the benefits of participating. And again, you will have access to practices and systems, heightened awareness of the best practices, and what we've seen with all our self-assessments is the eye-opening discussions. And again, as Becky mentioned, and is so important, this is a team effort. The assessments are not meant to be done by one person or one group of people from one department. It's supposed to be a team effort, and no matter how you may distribute it, that team should get together to review a lot of these items, and that is a lot of the positive feedback that we have received over the years. So that when you get that group together of physicians and nurses and pharmacists and risk administration, and you look at some of these items, and you may have people in the room say, oh, sure, we do that all the time, and some other people in the room may say, well, we don't do that on weekends, or we don't do that on the night shift. And that's an eye-opening discussion, because many of the other maybe leadership or department heads may not be aware of that. So that is something that then you could address. You could also address those items that you may not be at E. You may be at D, but actually have that discussion to say, you know, we have putting more time into getting something else done than to start that barcoding and PACU. So we aren't in E, but we know we're not in E, and we're going to put that on a time frame over the next year or so that we're going to work on. So again, it's those discussions too, and as Becky said too, if you keep notes, especially on some of those items that there may be controversy or that you want to set goals for, that is that great opportunity. And that helps you identify some specific challenges, prioritize your improvement opportunities. If you submit data to ISMP, you will get weighted scores and access to aggregate information once the assessment is closed. We did receive another question on will facilities be able to get weighted scores, submit responses after the December 15th. Now, after we close off the assessment, the weighted scores will not be available. You'll still be able to download the assessment from the website. And I'll say now that that date will be extended. We're not sure how long, but we will get something out in the newsletter on extending that date because we were a little late in getting it out from our original plans. But you get the weighted scores only if you submit during the submission periods to ISMP. You also could track experiences over time and meet and gauge compliance with managing high alert medications from some of the other agencies, such as the Joint Commission and their medication management standards, that it includes that the hospital has a process in place for managing high alert medications, that the hospital implements its process for managing high alert medications. And again, this is something that self-assessment will help you not only to do that, but also to help with the Joint Commission when they come in and ask you about that. And the same with the Center for Medicaid and Medicare Services and state health departments, because their performance improvement standards includes such things as the organization collects data to monitor performance, takes action on improvement priorities. At least every 18 months, the organization selects one high-risk process and conducts a proactive risk assessment. So again, hopefully that not only for the safety of the patients in your institutions, but also this will also help you meet and gauge compliance with some of the standards that are out there. Benefits on a national level, once again, when we get the information back after the closeout, we will have the workbooks for those who submitted information so that they could actually do some comparisons. We will be able to create a baseline of national efforts as we did with our prior self-assessments. And we'll be able to determine some challenges that healthcare providers face out there. And again, this is something that way back in 2000 or 99 when we began with our first assessment, these were things too that we had said, you know, ISMP gets in error reports. We are out there performing risk assessment consults in hospitals, ambulatory sites, and oftentimes we want to know what is the scope of some of these things that we see. Is that in more organizations or less organizations that we may actually be able to get involved in? So again, that's we use this information too to help develop tools associated with preventing harm from high alert medications. And in fact, that last bullet is something that we are committed to as part of our grant from the FDA. So once we get back information, we will be looking at some tools to develop to help hospitals. And finally, we do have, as Becky mentioned, we have the ability, or health systems have the ability to contract with ISMP. There is a charge for this because of our IT time and actually setting up the reports back to the hospital. But you could get a code, and we have some groups, organizations, health systems that basically have done this. And so we would assign them a group of codes. If there's 20 hospitals, it would be codes from 0 to 20, depending on what little term that they want to use with it. They would then assign it to their hospitals. And those hospitals, when we get the data after the close off, we'll basically pull that data, put it in Excel spreadsheets, send it back to the system, and actually then they'd be able to look at their individual system aggregate data. So that is something else that we have been offering with the other self-assessments, and also is something that we're offering with this self-assessment. And that way that system will be able to look at what are some system goals that they may want to look at. We've also worked with systems post that to actually help them implement some of those goals that they may come up with. So that's another offering that's available. You would have contact selfassess@ismp.org, and we'd be able to send you a copy of the agreement that we have, and then also the fees depending on how many hospitals are in your system. So I see we do have a couple other questions that came through. The one I did answer with the weighted scores and the Excel spreadsheet was another on vaccine confusion, pneumococcal versus flu versus high dose. And I'm not quite sure with that.
I think they're asking if it was considered for addition to the self-assessment.
Right, okay, I see the next box here. Yeah, and we don't have a vaccine section. So that is something that we did consider that, but it wasn't a section that vaccines are basically currently, they're not on our high alert list. Another question on, do you recommend physicians be included on the interdisciplinary team? If so, would it be a hospitalist or a particular specialty? We definitely recommend that physicians be on the team, and that could be up to the institution. I mean, hospitalists, great to have on the team. When you're completing the section on neuromuscular blockers and conscious sedation, we would recommend that you interact with anesthesiology with that. And again, since this is broken up into the categories, it is easier to have different team members maybe look at some of these different categories. So you may have different members come in and out. And we recommended that on our other self-assessments too, is that you may not have maybe respiratory therapy on each of the team meetings, but you may want to invite them to a team meeting to answer some questions on that pertain to respiratory therapy. So yes, we do recommend highly that physicians, and the specialty or that may depend on the category that you're looking at. Regarding the sign-in system, one person signs in for a whole system, but then how does each facility get added to that log? Is there a code that each facility will need to use when signing up? The assessment is meant for each facility to do on their own. So if your question is referring to the collaborative codes, each facility would get a collaborative code if you do the agreement with ISMP. But if you're not even doing that, but you have 3 hospitals, each hospital should do it on its own. And if you have an ambulatory surgery site, that ambulatory surgery site should sign up on its own. So that the assessments, and none of our assessments were set up for actually like a health system to do for their 8 hospitals, because as we all know, each site may have some individual practices. That's all the questions that I see on our log right now. If anyone else has any other questions, they could type them in. And there's a handout of the presentation. As I mentioned before, if you go to the handout, on the web that is available. And as Becky mentioned too, if any other questions do come up, you can send them in to ISMP on the assessment. And we do hope that everyone does have the opportunity to complete, if not all the categories, at least many of the categories of the assessment. I did say is that when we're going to extend the date, we'll probably do that within the next week, come up with a date, and hopefully have it in our newsletter, by which will be out, which is due out next Wednesday evening, Thursday morning. For we'll have the date extension, the time in that newsletter, if not before, on our website. Another question on anything unique for overseas participants. No, there really isn't anything unique. It's open up international, and with the demographic questions too, there is the drop down that you just put in which country that you may be from. It's the same way with the Department of Defense. They may be doing, we've had from our other self-assessments too, from other countries, even with the U.S. Army bases. So there isn't anything different that you have to do from an international scale. I do have one more question on those codes again, for part of a health system. As I explained in the last slide, you would get in touch with ISMP. There's an agreement that you would sign, and then also there's a fee to become part of a collaborative, and then ISMP would give you collaborative codes that you would then assign to the individual sites in your health system that they would actually put into that code. All right, I think, again, we could save a few minutes here from all of your days. That I think we have the we answered all the questions that we did get in. And again, if you have any other questions, you could get in touch with us. I want to thank everyone for taking the time to be with us. And also that I want to remind you that on Thursday, November 9th at 1:30, ISMP will be holding another webinar, and the title of that webinar will be Identifying Risk in Your Organization. Does Error Reporting Capture Everything? So that's November 9th, Thursday, November 9th at 1:30, and that is being advertised right now on our website, and hopefully many of you will be able to join us for that webinar. And I just want to thank Becky once again for going through all the information on how to sign up for this. All right, thank you.